So thank you for joining us this afternoon. I'm Zoe Clark, Senior Self-Management Programme Officer at NASS. I'm also a healthcare professional and have Axial SpA myself. And today I'm joined by a whole expert panel, so I'm very excited to have everyone joining us today. And we're going to be talking all about the recent British Society for Rheumatology guidance into medication for people with inflammatory arthritis when they're trying for a family, during pregnancy and during breastfeeding as well. So thank you all for joining us today. I'll ask everyone to introduce themselves. So Claire, would you like to go first?
Oh, hi, I'm Claire. I've got rheumatoid arthritis and I was one of the patient representatives on the project.
Brilliant, thank you. And next on my screen is Mark.
Hey everyone, I'm Mark Russell. I'm a rheumatology specialty registrar doctor and research fellow at King's College London, and I was involved in helping develop the guideline.
That's fantastic, thank you. And Ian?
Hello all, Ian Giles. I'm an academic rheumatologist from University College London, and I was the lead for the guideline that was.
Wonderful, and thank you all for your time in joining us today. It's a topic that we get a lot of questions on the helpline, so it's really helpful to get you here today to tell us about the guidance and give us an overview of the advice for people with axial SpA and a chance for everyone to ask their questions as well. And hi to Jane, who's joining us. Do let us know if you're watching, say hi in the comments, let us know where you're watching from. So before we get started, just to let everyone know, if you can't join us for the whole session, you can catch up on the recording afterwards. We'll keep it on our Facebook page, and also it'll be on our YouTube page and our web page as well. And we've popped a couple of links in the comments, so if you want to read the full guidance or listen to a podcast telling you more about the guidance, then do visit those links in the comments there as well. So before we hand over to Mark to do a presentation, Claire, it would be great as a patient representative, it would be great to hear from you sort of why you got involved in creating this guidance.
Sure. I wanted to be involved because I think when you're kind of thinking about having a baby, planning for it and pregnant, obviously it's really important that you fully understand what your treatment options are, even maybe ahead of being ready to try for a baby, sort of understanding what your next step should be, maybe making changes to your medication ahead of time. I had my daughter in 2018 and kind of went through that whole process and was really, lucky with the team I had that sort of held my hand right the way through it, including Ian, who's on the call. But the great thing about the guidelines is that they really open up this knowledge to everyone. So, us as patients can have a look, obviously the clinicians can share it with us, and it really empowers our decision making at this really crucial time in your life. So yeah, it's kind of a mixture of my own experiences and kind of wanting to support others through that important time.
That's brilliant, and it's really nice to know as well that there have been patients involved in creating this guidance through the process as well as healthcare professionals. That's fantastic. So Ian, these guidelines cover people right from when they're first thinking about having children, and for men and women as well, right through pregnancy and into breastfeeding. So what benefit do you find there is for patients in having this guidance available?
Well, the guidance that's just been published is an updated version of one that was produced and published in 2016. And one thing we were keenly aware of was that because of the increasing evidence that's produced on a regular basis in regard to existing medicines and new medicines, there's actually almost a constant need for updating information for both the healthcare professionals and patients about the medication specifically, which is the main strength of the guideline. And we also used a slight change with this new edition, used some general comments in relation to disease management per se as well. We hope will be helpful for both patients and healthcare professionals when thinking about this situation, both before, during and after pregnancy. Because one of the key things that's often forgotten is the importance of maintaining control of the arthritis itself. And you shouldn't just stop medications and hope for the best, because that actually can have an adverse consequence on them.
Absolutely, that's so important, isn't it? I think sometimes it can be overlooked as well. And we'll talk a little bit about when people can have these conversations with their healthcare professionals, but is there a particular time that you would recommend talking to a healthcare professional about your plans for a family when you have inflammatory arthritis?
It's a good question, and I think we're still perhaps reliant upon patients to deliver the trigger, because we're perhaps not always so diligent at remembering to ask the question. Perhaps when the healthcare professional might think about it is at the key points when they're thinking of prescribing a new medication, or increasing medication, or switching medication. So that tends to be at diagnosis, and then follow-up visits when people are reporting a change or an increase in their symptoms that might require a change in therapy. Hopefully at that point in time, the healthcare professionals should be thinking to remember to ask the patient what are their pregnancy planning desires, because that influences the choice of medication. And then patients are generally quite good at telling us very quickly whether that's something that's relevant to them now, in the medium or distant future. It's been quite important to factor into the medication decision planning and making process.
That sounds really sensible. And I know we had a question before the session that someone left in the comments that Mark's going to cover in his presentation shortly, and that was asking for men in particular about medications and whether you should stop them before trying for a baby as well. So it'd be great to hear from you. So if you're ready, Mark, I'll hand over to you and for the short presentation and overview. But for everyone watching, if you have any questions, please feel free to pop them in the comments, and we'll come back and answer those in the Q&A. Thanks, Mark.
Thanks, Eri. So I just thought I'd sort of run through, there's lots of information in the guidelines, in both guidelines that we've published, but I thought I'd give a sort of a summary of some key bits that might be relevant for patients with axial spondyloarthritis, and then signpost you to where you can see more information. So the first thing just to mention, which Ian just talked about there, is the two previous guidelines were published 6 years ago now as two guidelines or two parts, and we've now completely separated those out. So the first guideline looks at what we call DMARD, so disease-modifying drugs, for example, sulfasalazine or the biologic medications that we prescribe to try and control the underlying disease or condition. And then the second guideline looks at medications that are not the disease modifying ones, but perhaps might be prescribed during pregnancy. So for example, pain medications, medication to control blood pressure. And the need to update it was, as Ian mentioned there's been lots of new evidence since the last guideline was published, particularly for the biologic drugs, so drugs such as anti-TNF molecules. And just very briefly, in terms of development, so the two guidelines are similar in terms of what we did to try and bring together all this evidence, with some slight differences. So for the first guideline that looked at these disease-modifying drugs such as sulfasalazine, we looked at all available evidence, lots and lots of articles out there. We tried to take the relevant articles and then bring the evidence together with that from the previous guidelines and give some recommendations on actually 34 drugs now, including the two that I've mentioned there. Whereas the guideline for the other medications, we recognize that actually various other guidelines and reviews, etc., have already looked at these medications, whether it was in rheumatic conditions or other conditions. And so we took the highest available evidence there was, brought that together with the previous evidence, and also formulated some recommendations on drugs. And that includes non-steroidal drugs such as ibuprofen, as well as other pain medications. And the questions we were trying to answer were the same for both guidelines. So should the drug be stopped before trying to conceive or conceiving, or can it be continued throughout pregnancy? Is it safe during pregnancy? Is it safe whilst breastfeeding? And then also, is it compatible with paternal exposure? So men who are trying to conceive with their partners. And there's lots of text on here, but this is just to highlight a few of the general recommendations, the ones that Ian mentioned earlier. So this is not specific to a particular drug, but they're just sort of general comments that might be useful for when patients are speaking to their medical team before conceiving or during or after pregnancy. Just to pick out a couple of key points, we've mentioned the importance of preconception counselling to try and make sure that the underlying condition is as well managed as possible, both before and during pregnancy. We recommend, if at all possible, to avoid pregnancy incompatible drugs that we would not generally recommend during pregnancy unless absolutely necessary. and recommend that where people are on those medications, ideally they would be switched to a pregnancy compatible drug before conceiving. But we also recognise that there are some, fortunately, relatively rare situations where women have severe or life-threatening underlying disease, and that we sort of emphasise that the control of that disease takes priority. And so if there is a medication that needs to be continued to make sure that that is well controlled, then we would that would be the priority. And that goes for the biologic medications we talked for. So there is increasing evidence that the majority of those medications are safe during pregnancy. And if they are needed to control severe or very active disease, they could be continued after discussing the risks and benefits with between the medical team and the patient. And this is something relating to that comment you said, Zoe, which I'll come back to later. The evidence behind paternal exposure to these medications, so in men who are trying to conceive with their partners, is increasing, and for the vast majority of medications, there is no signal of harm, and they do appear to be safe. There are some drugs that at least temporarily can affect fertility in men, but we will come back to that later, in particular with sulfasalazine. So just to pick out some relevant drugs that we cover in the guidelines, perhaps relevant to axial spondyloarthritis. So NSAID. So these are non-steroidal anti-inflammatory drugs, for example, ibuprofen or naproxen, and then also the newer category or the more selective category of drug, such as atoracoxib and celecoxib. So the evidence for this, there is increasing evidence. There are some sort of discordant findings there, where some studies agree with each other, some don't necessarily agree. And so based upon the evidence that we found, we recommend that if those medications are used in the early part of pregnancy, ideally they would only be used intermittently rather than sort of regularly or at regular high doses. If they are then used in later pregnancy, they would ideally stop by gestational week 30. And this is to avoid what we call premature closure of the ductus arteriosus. So this is one of the important vessels in the fetus. And if non-steroidal drugs are continued later than that, there is an increased risk of that closing earlier. And so the recommendation is, if at all possible, that they should be stopped by week 30. The other category, the selective category of drugs like atoracoxib and celecoxib, there's much less data available in pregnancy for those than, say, for drugs that have been available for much longer, such as ibuprofen. And therefore, based on that, we say that ideally they would be avoided, as there is too little evidence to support their use during pregnancy currently. But non-selective drugs, for example, ibuprofen, do appear to be compatible with breastfeeding. Just to touch on some other pain medications, and so for example, paracetamol, we recommend that this is the analgesic of choice. So if a woman who is pregnant has pain that needs controlling, paracetamol would generally be the safest option to use, and it also does appear to be safe during breastfeeding. Codeine, again, some conflicting evidence with this medication, and so the recommendation is to avoid long-term use where possible during pregnancy and in the periconception period, and also caution during breastfeeding. And this is mainly due to unpredictable metabolism of the drug between individuals, and so it's quite hard to predict effects on the breastfeeding infant. And we recommend avoiding tramadol during pregnancy due to some evidence of harm in some published studies. Sulfasalazine, so this is one of the disease-modifying medications that can be prescribed in axial spondyloarthritis. And as with the previous guideline, we recommend that this is compatible throughout pregnancy and can be taken. We recommend folate supplementation at least during the first trimester. And it also appears to be compatible with breastfeeding as well in full-term infants. I just thought I'd touch briefly. So methotrexate is not used widely in people with axial spondyloarthritis, but it is in other conditions, for example, psoriatic arthritis. Now, this medication we don't recommend during pregnancy, and we recommend stopping it at least a month in advance of planned conception, and ideally switching it to another pregnancy-compatible drug. But we do say that in people who have unintended pregnancies whilst taking methotrexate, there is increasing evidence that the risk to the fetus appears to be relatively small. So we would recommend stopping the methotrexate, prescribing folic acid in the first trimester, and then referring on to a fetal medicine specialist for review. Touching here on one of the important biologic medications that is frequently prescribed in axial spondyloarthritis. So this is TNF inhibitors such as adalimumab, certolizumab, and infliximab. So there's been lots of evidence since the last guideline on use of these medications in pregnancy and with breastfeeding. Just to touch on a couple of points here. In women who have well-controlled inflammation or well-controlled underlying disease, who are already on a TNF inhibitor medication, they do not need to switch that particular drug to another TNF inhibitor that we know has lower placental transfer, which is certolizumab. So if they're on, say, adalimumab, they can continue that medication at least until the later stages of pregnancy without having to switch it before trying to conceive. Mentioning specifically certolizumab or Cimzia, if the woman is on this medication, that has minimal placental transfer and so can be continued throughout pregnancy and during breastfeeding. For women who are on the other anti-TNF molecules, so adalimumab, golimumab, etanercept, and infliximab, they can continue that during pregnancy, at least until the later stages of pregnancy. Then in women who are felt to be at low risk of disease flare on stopping these medications, ideally would stop them at the time points mentioned there or before that time period. And that would then allow the infant when born to have a normal vaccination schedule, including live vaccines. This relates back to the earlier point, though, if it is felt that the TNF medications are needed throughout the whole pregnancy, they can be continued. In those circumstances, for the infant, we would recommend avoiding live vaccines in the infant until they're at least 6 months of age. And so that would be, for example, BCG vaccine or rotavirus. And they do, these medications do appear to be compatible with breastfeeding as well. Final couple of slides just to touch very briefly. So the interleukin-17 inhibitors, these are drugs such as secukinumab and ixekizumab, are increasingly used in axial spondyloarthritis. There is not, because they're newer, there's not as much evidence as there is for TNF inhibitors, but the evidence that there is doesn't appear to show any harm during pregnancy with use of these drugs. There isn't enough evidence yet to say that they are very much compatible with pregnancy, and so generally we would recommend stopping them if possible at conception. But if there was exposure that happened, or if a woman conceived whilst on them, it is thought unlikely to be harmful. And if they are thought to be needed throughout pregnancy to control maternal disease, then they can be continued after a discussion about risks and benefits. And this is just to go back to the recommendations for men who are trying to conceive. So the first thing to say is that the vast majority of disease-modifying medications and other medications appear to be safe during paternal exposure. One medication in particular, just to comment on, which is sulfasalazine. So there doesn't appear to be a signal of harm as such for children born to men who took that whilst trying to conceive or after having conceived with their partner, but it can sometimes reduce fertility. And so it doesn't need to be stopped in men who are trying to conceive. But if, for example, there is conception is delayed by, let's say, more than 12 months whilst on this medication, then at that point it might be reasonable to try stopping it after speaking to the medical team, as well as investigating other causes of reduced fertility. But just to point out there that for TNF inhibitors and interleukin-17 inhibitors, they do appear to be very much compatible with paternal exposure. And then just finally, this is just to show, so, there's lots of information in the guidelines. There is both an executive summary of both guidelines, which just has the key recommendations, as well as some helpful tables here, which are sort of quick reference tables to have a look through each stage of pregnancy and with paternal exposure, whether we feel generally, or whether they're felt to be safe or whether they should be stopped. And then there is also a full guideline for each online, which has all the underlying evidence that helped us formulate our recommendations. So I will pause there and hand back over to Zoe.
That was wonderful, Mark. Thank you. It was a really good overview because they are quite chunky guidelines when you first take a look at them. So it's really good to get that breakdown, particularly specifically for people with axial SpA as well.
No problem.
And we should hopefully have Ian joining us as well. I can see he's still there. Perfect. Hiya.
Hello.
Yeah, I can already tell that the recording for this session is going to be a really great resource for us to signpost people to as well, to get a little bit more information, to help them have these conversations and prepare for them. Claire, as you're involved, as we said at the beginning, so from the patient perspective, do you think with patients having access to these updated guidelines, it'll be helpful for them in having those conversations and preparing for them?
Yeah, definitely. I think, at any time information is power, and being able to kind of swat up as much as possible, particularly like before appointments, so that you've got all of your questions prepared to ask. And also I think sometimes with prescribing, it can be a mixture between the hospital and your GP and things like that. So kind of knowing who to speak to about which bit, and make sure you're getting the right medication, whether it's folic acid or whatever that you need. I think just having that table at the end is so helpful, isn't it? You can just get scanned down and be like, okay, fine, I've got a headache, I can take paracetamol, that's okay. And kind of, so it's not only for the planning stages, it's, when you're actually pregnant and you're second guessing yourself, because I think when you're pregnant, you're, this heightened state of awareness of your health and its impact not only on you, but on your baby. So having that resource there to check, have those conversations, whichever professional it might be, it's just, brilliant.
Absolutely, and particularly when you're dealing with pain as well. We know that many people through pregnancy with axial SpA, their symptoms can improve, but of course, some people can have those flare-ups. So it's really great to have that clear guidance saying what is safe to help in those times as well. That's brilliant. And we've touched on this a little bit in terms of how hopefully the guidance will be helpful in kind of having those discussions around balancing kind of the risk of pausing or stopping medications and trying to balance looking after your axial SpA with then the plans for having children. Ian, do you want to tell us a little bit, sort of expand on that a little bit more about that kind of balance of risk versus benefit?
It's, it's an important point to make in that it's definitely, there is a risk benefit balance, and that's what's I think the full text sort of underlying or outlining the evidence we draw upon to make the recommendations. The evidence is written at length in the full length guidance, which is a weighty tome, and can, if you are unable to sleep, it can perhaps serve in that respect, and it's perhaps a little bit undigestible for the lay reader, but it just at least shows people that there's sometimes it's not always a simple black and white decision. We've mentioned the summary table, which is the one thing that most people look at, and it's of course it's a great reference because everyone wants to know yes or no, is it safe, and that's what we've tried to do and pull into that table in a very simplistic fashion. But when you look in more closely, you'll see that there are little footnotes to the table, so there are lots of caveats around some of those yeses and nos, because it's often yes but you have to be careful around this circumstance, or you can perhaps take it at this stage of pregnancy but then stop it at a later stage of pregnancy, or vice versa, and that advice differs for different medications, and that's doesn't really come across in that same way in the summary table, and isn't always conveyed in the recommendations either, because we had to take a lot of information and try and put it into what we hope is a simple and more digestible terminology in the actual recommendations. And one thing I'd learned from the first edition was that where I thought we'd done that successfully for certain medications, the number of times people kept telling me with great conviction that they did such and such because the guideline said so, and I'm scratching my head saying that's not actually what the guideline says, or that's certainly not what it intended, where was what we tried to then avoid by putting a lot more recommendations to try and explain things a little more clearly around the decision-making process based upon the evidence. So it is very much a risk-benefit conversation, and it's one that hopefully with the guidelines there, people can then have that informed conversation between the healthcare professional and the person with the condition to then decide upon what's the best option for them, because often it's individualization of that approach that has to take place. It doesn't always translate quite so simply as the yes no from the summary table. That's important to bear in mind, and of course they are guidelines as well. They shouldn't be taken as dogmatic fact that you must take or not take the medication at a certain stage, because there are certain nuances around that. And I think that hopefully will then lay the foundations for the informed conversation that can take place at the relevant time.
That's really helpful, and I can see that it can't have been an easy task condensing all of that information and research down into the guidance, but I think it's definitely going to be a really helpful tool for people to help in those conversations and in decision making as well. So that's brought us to the end of the sort of questions we'd prepared beforehand. So we've got time for a few questions. If anybody has anything that we've not covered already, please do pop that in the comments if there's anything you'd like to ask the panel. And while we're waiting, any of you speakers have anything else you wanted to add? Although already shared a lot of information, thank you.
I think we might have forgotten to say that there are other podcasts available. If you go to the British Society of Rheumatology website or search for Talking Rheumatology, we were all involved in a podcast that was produced for the Rheumatology Journal to think with the launch of the guidelines. So that talks about the guidelines in a little more detail in relation to some other aspects in a podcast that was hosted by Marwan Bakari, journal editor.
Oh, fantastic. Great host to have as well. And we've popped the link to that in the video comments as well. So if you're watching this on Facebook, you can check that out in the comments. And if you're catching up on YouTube, we've put it in the video description as well. So you'll be able to head over and listen to that as well, get a bit more in-depth knowledge. So that's wonderful. So we haven't got any questions coming in at the moment, but what I'll do is I'll keep an eye out over the next couple of days. And if anything comes through, are you happy if I forward them on to you all and I can then respond in the comments? Wonderful, thank you. So just to let everyone know, our next Facebook Live is going to be on Wednesday, the 11th of January, and that's at 1 p.m. And I'll be joined by physiotherapist Claire Jeffries, and we'll be talking all about mobility aids for people with axial SpA. So that's everything for today. So thank you all so much for joining us, for everyone for watching, but also for our expert panel as well. It's been fantastic having you join me this afternoon and share all that information with everyone. So thank you.
Thank you very much.
Great. Yeah, thank you. Thank you, Zoe.
Take
Thank
care,
you, everyone, for
everyone.
watching.
Thanks, Zoe.
Thank you.
Take care. I'll stop the